सर मैडम ज्वाइन हो सर। बिनु सर।
Hello. I think
सर मैडम ज्वाइन हो सर।
Madam has joined. Madam is trying to reconnect with, I think,
ओके।
audio, but she's there, I think.
मैडम ओनली फर्स्ट स्लाइड सर, एक्चुअली शी हैज टू स्टार्ट। दैट इज द रीजन आई एम वेटिंग सर एक्चुअली।
Madam has joined.
He was there, na?
हाँ
Just
मैम, शी वाज
She's
देयर।
there also. Now in the
yeah,
list also she's there.
yeah. Maybe some connectivity problem is there.
Good morning to everyone.
Good
गुड
morning,
मॉर्निंग
ma'am.
मैम।
Good morning.
I thought you have started already, but let me start. Just
Good
go
morning,
on.
ma'am.
Yeah, good
गुड
morning
मॉर्निंग
to
मैम।
everyone. Muttuji, go on to
यस
my introduction thing. Next.
यस मैम।
Yeah. Well, I will be short on this myself introduction. Good morning to everyone. I received a doctoral degree and then 45 years of experience, life member of many societies, and I had been a chapter president for TNI Overseas Branch, and also now founder and patron of 3 societies, and awarded and felicitated. The best part was my trip to India, and I thoroughly enjoyed it with lots of experience. And next. Next, please.
यस मैम।
Next. My respected dignitaries, presenters, and lovely audience, welcome to our NSS webinar series number 4. And we have a set of other talented research presenters who worked very hard and followed the strict protocol of conducting their scientific research studies and obtaining their doctoral degrees. I'm confident that the findings of each study will add to your skills and standards of nursing care in providing quality care to your patients. I'm doing the first part of the ceremony by introducing our all guests. My best wishes and God's blessings to all of you. Next, introduction of NSS President. Our National Founder President, Professor Dr. Binu Job, is a gold medalist currently working in Rajkot as a principal. He has 16 years of professional experience and is very active in enhancing our mission. He has conducted many national and international workshops and has been proponent in our successful recent international conference in Copenhagen and with the Vibrant College of Nursing in Surat. He has published many research articles in reputed journals and has written a textbook on pediatric nursing. Sir is a lifetime member in many prestigious professional societies and is on boards of reputed nursing journals. He is pillar of our nursing scholar society, and I would like to invite him for his message. On to you, Binu sir.
बिनु सर।
Yes. Respected, a very warm greetings of the day and namaste to one and all. Yes, research is a very essential for the advancement of the healthcare. Research plays a very crucial and a very vital role in improving the lives of humankind and strives to provide the best quality care. Research helps to enhance the standard of our nursing profession and also helps to provide deep insights and the facts with the proper scientific evidences. Yes, our Nursing Scholar Society's main vision is to promote scholarly activities, either in the form of written and in oral, for all the overall development towards the quality of the nursing profession. And yes, it's really great movement when our own founders of the Nursing Scholars Society, like Dr. Neeraj Sood ma'am, Dr. Rita Lakhani ma'am, and all who are presenting today, share their valuable knowledges of research among the fellow professionals in continuation with the presentation series. I'm really excited to be part of this research webinar series on the research and really very eager to hear from a great mentor. She's a very great enthusiastic researcher, Dr. Neeraj Sood. Thank you, ma'am. Thank you all.
Thank
Okay, proceeding with that. Thank you, sir, for your valuable words of encouragement. We are just going through the brochure, history and on this objectives and all we have read already. But just to say that we have our chief guest, Professor Dr. Priyesh Jainji, and then keep next slide, please, Muthuji. Next
Yes, ma'am.
slide. We had a special two guests that Dr. Asha Qureshi, I will introduce you later, and Dr. Bimla Kapoorji. Now, first is our chief guest, Professor Dr. Priyesh Jainji is currently working as principal at Kamdar Nursing College and is our founder, vice president, and today is also our chief guest. He wears many hats of responsibilities, such as Gujarat Nursing Council, board member, and various referee journals, chairman of examination, examiner in many universities, and executive of NSS Together Society registered in Gujarat state. Sir has presented and conducted many workshops and conferences and has organized many major events, including this recent celebration night of 20th college establishment anniversary. I was lucky to be there in person and just witness the beautiful ceremony with 2,000 students. And you might have seen many photos on social media. On to you, sir, to deliver your valuable message. Priyesh Jainji.
Yes, a very actually Priyesh sir was very busy. Actually, we are expecting our Honorable Prime Minister Narendra Modi, Shri Narendra Modi ji. On today, we have an inauguration of our Rajkot Hospital, a super speciality hospital dedicated for mother and child welfare. A 2,000 bedded around hospital is going to be inaugurated. So, sir has been given responsibility of coordinating the whole division of the Rajkot division. So he will not be present, but I will read his message on behalf of him. Respected Dr. Suresh Khanna ma'am, myself, eminent nursing members, and renowned participants, a very warm greetings to all. The renowned sociologist specifically said that research is something that everyone can do and everyone ought to do. It's simple collecting information and thinking very systematically about it. Thus, the importance of a research in PhD attains a very higher levels of recognition as they are the results of exclusive modes of critical analysis. The importance of research in the scholarly activities and doctoral study is also very vital. It is based on comparative, descriptive, and correlative.
There is some problem in the audio.
No, ma'am. Binu sir?
Binu.
Binu sir?
Yes, yes.
Very
I was audible.
Yes, now you are audible.
Okay. So he actually, sir, that's why he was very busy in his schedule as because of the inauguration, and actually that's why also we are also busy with some or other works given by all the Rajkot division medical superintendent in coordinating the activities. That's why sorry I'm not able to on the video, I mean, near a crowd-like destination. Okay, good wishes he has told for the event. Thank you. Muthu sir, you can continue.
Yes, yes, ma'am.
Next,
Ma'am,
please. Next slide. And I don't know what happened to my video. I cannot see you all. I can see you all, but I am not coming on. Go to next. Introduction of
Ma'am,
Professor Bhim. This time I will only say that she had a right knee surgery and is in the hospital, and we would like to play a very small clip video. See, go to the video clip, please.
yes, ma'am.
Thank you, and best wishes to her for her speedy recovery. Go to next slide after that, please.
Yes, ma'am. Next.
Asha ji. Professor Dr. Asha ji is expert from Belgravia University and past Joint Secretary of First Dr. Lavender of Delhi NCR. SNP, she was working as a secretary there. She is a member of various boards such as the Examination Board, Selection Board, Advisory Board, and member of many other boards, etc. She is a recipient of more than Best Research Paper Presentations. Her awards and accolades include Award of Excellence by President of India, Shri Shankar Dayal Sharma ji, and Rajiv Gandhi National Unique Award, Best Woman of the Year Award from NSF. Madam is life member of many professional societies. I invite Professor Asha ji to give her blessings to the presenters. Dr. Asha ji, on to you. She is mute. Unmute. Unmute her, please.
Yes, ma'am. Just a minute, ma'am.
Unmute her.
Yeah. You can hear me now?
Yes, ma'am.
Now you.
Yeah. Namaskar to everyone. Good morning. And, I can say that it's a really good initiative taken by our NSS family and given the opportunity to all the scholars to present their views and present their research findings and all. Many times, the dissemination of these findings
मैम आप म्यूट हो गए मैम अनम्यूट करिए आशा कुरैशी मैम अनम्यूट करिए अपना माइक मैम
Okay.
आप हाँ आप हो गया
Yeah, you can hear me now?
Yes, ma'am.
So our NSS family has given us the opportunity to present and share the knowledge here in this scholarly forum, which is made, and it is really a good initiative. I appreciate it. And all the scholars who are coming over here are senior people, and all the new students and all, everybody is allowed to have the presentations. Where it is not possible for this type of presentation in any of the forum, whereas here the encouragement is given, recognition is given for all the scholars. They are presenting and showing us the path of light and how to disseminate the finding and how to use his knowledge in the clinical area and in the nursing profession. With this, I just congratulate and give best wishes to all the presenters who are presenting today. Thank you so much.
Thank you, Jay. Next slide.
Yes, ma'am.
I'm going to introduce Professor Dr. Geeta Parwandaji, who is our guest of honor and wearing another hat of research person. Doctor has a PhD in nursing and ex-captain of military nursing service with an ample experience of clinical teaching and administration experience. Currently serving as principal and dean, Faculty of Nursing, Swami Vivekananda Subharati University, Meerut, with the career objective to be a leader in educating and preparing nursing care human force of international standards who will serve the needy. Holding the additional post of Society of Midwives and ANEI Secretary, UP chapter since 2016. Honors and awards. Best Officer Award in Army in 1991. Best Teacher Award year 2004 from Lion Club, Mahanagar. Best Principal Award year 2007 from TNEI, UP State. Excellence Education Award from International Institute of Education and Management in 2011, nominated as Chairperson, Nursing Service and Nursing Education of TNI and UP State 2012 and 15. Best Citizen Award from International Publishing House, New Delhi in 2013, Award of Extraordinary Contribution to the Field of Nursing for IMS 2014, Star of Asia Award by Global Achiever Foundation, Kathmandu, Nepal on 2nd August 2014, nominated as Chairperson Nursing Education of TNE UP State 2015, and as Shahar Medical Science Award 2018-19 by Samaj Vikas Sansthan, Meerut, PER FECIO Award 2020 by DHS Foundation in association with Campbell University, USA. Lifetime Achievement Award from Nursing Scholars Society in 2021. Indian Academic Leader Award from International Research Association, England in 2022. ICM Conference 2022 Research Reviewer chaired the session in ICM Bali, Indonesia in July 2023. The reason I read in detail is hats off to her that she has done so much in her career. Total publications 50, copyrights 03 registered, number of conferences, and PG research guided 78. So I think she is a mentor to many of us and especially to her students. Next slide, please. I invite Geeta ji for her message, please.
Jai Hind and greetings to all. First of all, I would like to give my special greetings to renowned Honorable Dr. Subresh Khanna Madam, Professor Dr. Binu Jha, and eminent all esteemed NS member on this platform. Ma'am, I am a very young researcher and I really thankful that you have given me opportunity to be in front of Dr. Rimla Kapoor ma'am, Dr. Ashia ma'am. I think they all are my guides, and I'm very young in this journey, but I'm so thankful that I am here as a part of this, under this NSS umbrella. And once of all, I offered my sincere thanks again to give me the opportunity to be as a guest of honor. And I am really so delighted that ma'am today, Madam Nirja, Dr. Rita, and all the eminent PhD guides are there to share their research thoughts, and we can have a sharing of knowledge platform. As we know, in higher education, which is a very important sector for the growth and development of human resources, which can take the responsibility of the social economy and the scientific development of a country. And research is a continuous process in higher education for the identification of a new problem, creation of a new knowledge in a given subject, and the most important thing is the interconnecting and interrelating the different subject by identify the new policy regulation of a country. So once again, we are here to get the knowledge from our respected senior PhD guides for on their research topic, and let us see how it comes up to the new path. Thank you, greetings, and Jai Hind to all. May God bless us with the good health to make this event a successful and the enjoyable one. A great initiative from NSS under Dr. Khanna Madam's guidance. Jai Hind.
Thank you, and you will be still around because you are our resource person, madam. Okay, next is our Professor Dr. Muthu Chawda Nawarji. His academic background. He has completed MSc Nursing Community Health from RGUHS and BSc Nursing from RGUHS, and pursuing PhD from Nirvana. Now you have done already. You're a doctor. He has completed PhD from HEPU, and now he is awarded certificate of clinical audit by NAB. He is a certified LEAN 6 Sigma by XLNC Academy International Private Limited, green belt, yellow belt, black belt. Ooh. He is also certified FCEM from RGUHS Bangalore. Training of trainers taught. Course in midwifery faculty development program from NRSC New Delhi. Professional backgrounds. Working as quality consultant at Karnataka Institute of Medical Sciences, Hubli. He has more than 15 years of clinical teaching and has administrative experience in the field of nursing and quality and administration. He has worked as NAB consultant and certified 10 hospitals for NAB entry level and full accreditation. He's a certified internal assessor of Kayakalpa, NQAS, MUSQAN, and LAQ SHYA program. Next slide, please. Publications and presentations. Published many research papers in reputed nursing journals and research is in progress. Third one, reviewed many textbooks in nursing. Life membership is in TNEI, Nursing Scholarship, Nursing Research Society. And also he is our chapter president of Karnataka State's Saitya, number 15. And also he is very, very active. The minute I call him, and he will be ready to help us with so many PPTs. He has done it, no matter what I say, what I do, but the end result is beautiful. Thank you, Muthu sir, and I invite you for your message.
Thank you, ma'am. Thank you for the introduction. Thank you so much. Respected Khanna ma'am, Patran ma'am, Benu sir, President, and today's resource person, Dr. Geeta ma'am, and guest of honor and eminent NSS member, and all the participants. It's my honor and pleasure to be here as a guest of honor and master of ceremony in this research presentation series. Nursing research has a tremendous influence on current and future professional nursing practice, thus the rendering it an essential component of educational process. This research presentation series are providing opportunity to the students, clinical nursing personnel and faculty members and budding nurses to gain knowledge from their nursing leaders and disseminating they utilize their research findings in different areas. I would like to thank to Dr. Khanna ma'am for initiating and providing the platform for nursing personnel to disseminate their PhD work with others. I wish to all our today's research presenter that your productive work will be utilized by the individual and the society.
Sir, I
Now,
invite you to now start your MSc part, please.
yes, ma'am. Thank you. Now, I would like to call Professor Dr. Nirja Sood ma'am to present their scientific presentation.
Thank you, Dr. Muthu. And I hope I have a screen sharing option. Is there?
Ma'am, it is there, ma'am.
Let him give your profile, madam.
Okay.
Introduction about Professor Dr. Nirja Sood ma'am. Madam has completed PhD in Public Health, MPH, MA in Public Administration, MSc Nursing, BSc Nursing, Postgraduate Diploma in Distance Education and Postgraduate Diploma in Bioethics. Completed various online short courses. And Madam is has done Foundation for Advancement of International Medical Education Research, Fellow on 2014. And professional experience around 40 years in clinical public health administration education. At present, working in a School of Health Sciences, Indira Gandhi National Open University since last 16 years. Madam is a PhD program coordinator, program and course coordinator of a Diploma in Nursing Management program. Member of board studies, member of doctoral committee, supervisor, evaluator, and examiner for PhD and PhD supervisors. Madam has received award for Best Judge Reviewer in the International Conference in 2015 and 16, 17 and 18. Madam has worked in Delhi government, DHS for 22 years. First Registrar, Delhi Nursing Council, worked in National Health Programs, team member for establishment of National Rural Health Mission in Delhi, honorary nursing consultant to the Delhi government, and resource person for planning and organizing the first induction training of nurses in Delhi government. Madam is a resource person for training doctors, nurses in hospitals and Delhi Directorate and TNI, College of Nursing and CNRS, resource person in various projects, member of PAY 6th and 7th Commission Committee at TNI. Published papers in international and national journals in nursing, public health, and open distance and online. Blended educations, presented papers in national and international conferences, editor and reviewer in national and international journals in the field of public health and nursing. Member of various professional associations and societies. Madam is a chairperson for research committee at CNRS, and Madam is the president of NSS Delhi chapter and received Lifetime Achievement Award from NSS in 2021. Now I would like to call Dr. Nirja Sood ma'am to present their presentation.
Thank you. Just give me 1 minute to share my screen.
Please, ma'am.
Is it visible, my presentation?
Yes.
Yes, ma'am.
Okay. Thanks. First of all, I am really thankful for providing me an opportunity to present my findings of my study. And I am really grateful to Dr. Sue Khanna ma'am for pushing me to present it, because due to such, thank you ma'am for that. Although my study is very different study from other nursing studies. So in this study, mostly I have taken the background and findings related to nursing services. That is one aspect of my study. If you see my topic, that is changes in Directorate of Health Services Delhi during 1990s. Approaches of the health sector reform of 1990 brought in shift from welfare to a market model and cut back in the social welfare sector. Despite a policy return to strengthen public health system, impacts of reform initiated in 1990s were also visible in the 21st century. 1990s is seen as a marker of the beginning of health sector reforms in South Asian countries. The World Bank stated that during the later half of 1990s, government of South Asian region countries began the initiatives of reform, informed by the ideas designed as given in the WHO report, Investing in the Health. Health policy of these countries sought a more prominent role for the private sector and NGOs in the provisioning of services. It clearly stated the inability of the state to provide services and also allowed and encouraged private practice by the government doctors. If you see, the public spending has gradually increased from 0.22% in 50s to 0.8% in 75-76, then 1.05% of GDP in 1980s, but it was stagnated after that. During 75 to 85, public spending increased to 1.05 of GDP. There was a steady decrease during the 80s. Health sector reform of 80s and 90s were adopted all over the world, but the degree and the forms were very different. Reforms has stressed on the cut in the health sector investment by the government, strengthening of public health sector infrastructure through the participation of private sector, opening of tertiary medical care to the private sector, and many more technological interventions in the public health sector were carried out. Debates on restructuring of health services to provide optimal care and hence quality has been the active one since then. After the 2000s also, there has been a recognition that there is an importance of public sector. If you see, in 2000s, many reforms have taken place again towards the primary healthcare and the public sector. In India, the 1990s was a period of major shift in economic and social sector policies, and this has an impact on health services also. Policies sought to strengthen the dominance of largely unregulated private sector, confirming that public sector is only for preventive health and primary health care, and private sector is for curative care. India adopted two economic structural adjustment policies of the International Monetary Fund and the World Bank, which included cutbacks in subsidies and the public spending on the social sector, especially in the education and the health sector. Despite the fact infectious diseases were re-emerging and the mortality and morbidity was very high, still a selected national programs were given importance, that is tuberculosis, leprosy and AIDS, because India was getting grants from the foreign countries and they had to pay back these grants with the high interest. Non-communicable diseases again was given importance, that is cancer, diabetes and heart disease, which they occupied the major place in the plan documents rather than the non-communicable diseases. And gradually there was a reduction in the role of a state as a major provider of the healthcare services. It has been argued that the World Bank and IMF has undo what the directives of Bohr Committee in 1946 stated, that state is responsible for provisioning of the health services. The market has played and the private sector has played an important role in 1990s after the health sector reforms. Government of India tried to incorporate some reforms in the administration of health through the National Rural Health Mission in 2005, increasing the public expenditure. It has increased to 1.04% of GDP, but still it has not reached the goal of 2 to 3%. If you see, again the concept, if we say 1978, it was health for all, but in between there was health sector reform wave was there. Again in 2000s, again public sector and the primary healthcare has gained the importance. What was the need of the study? In order to understand the development of health services over the periods in 1990s, it was important to study the changes in health services as they were actually occurring at the ground level in different contexts. It is necessary to understand and analyze the changes in organizational structure, functioning and decision making. Because it is nursing or medical or health services, it is very important to understand how the systems are working, what are the organization structure functioning, who is making decisions, and how the decisions are being changed. It impacts the professional output of the person also and the health services also. As the provision of services in India falls under the jurisdiction of state government, State-specific studies can reveal a great deal about the actual state of affairs and impact of such changes. Among the Indian states and the Union Territory, Delhi holds the unique position of being the national capital city with higher central and the state funding than the other states. Delhi had its own specifications and specializations in terms of health services. Against this backdrop, this study of organizational structure and functioning of Delhi Directorate of Health Services and changes over the decade 1990s was studied. Directorate of Health Services is the technical wing of the public health services structure, which is meant to plan and oversee the planning, provisioning, and regulation of health services in Delhi. The objective was to document the nature and processes of change in Directorate of Health Services over the 1990s by using a systems approach. This approach was expected to elicit the dynamicity and complexity of the health services organization, its structure and function, and understand unfolding of changes in the health services in Delhi during the health sector reform and thereafter. The historical and multidimensional approach to health system research adopted for this study allow examination of complexity of the system without reducing it to only a few variables or components while keeping in view a single researcher study. The DHS was viewed as an open system with several subsystems. I will just show the conceptual framework. Just give me 1 minute. There is some problem with my presentation. Why I'm not able to? One minute. It is. Just give me 1 minute. Is it visible, my presentation?
Yes, very clear.
Okay. There is some problem actually. Can I show it from my other file? I will show you. Maybe later I can show if it's okay, because there is
Yes.
some problem. I'm not able to open the file. The role of DHS emerged from a systems framework and its linkages, structure and functions were explained. The relationship with the Department of Health and Family Welfare, Secretariat and other outlets, external linkages and the external linkages. The questions were, what changes have occurred in Delhi administration, public health system and Directorate of Health Services since 1990s, and why and how these changes have occurred. Methodology was qualitative descriptive study aimed to document and analyze the organizational structure and functioning of Directorate of Health Services of Government of Delhi. Then it was known as Delhi administration over the 1990s. The components which were studies were provisioning of general medical services, provisioning by dispensaries. 2 hospitals were taken. One was established in 1990s and other in 2000. Outreach services, school health scheme, mobile health scheme, and one national program was studied, and one role of regulatory sector, that is nursing home cell, was studied, and the planning cell. The data collection, it was purposive, extensive secondary review was done, various visits was carried out. I will show you later on. Participatory observation, interview, focus group discussion, checklist, schedules, and focus group guides were used in the study. Quantitative and qualitative data analysis, triangulation was done for comprehensive understanding for the validity of the information from different sources. Data triangulation was also done and various methods were used to study a phenomena, help in increasing the validity of information and understanding of the phenomenon. Some of the findings, even before, Delhi was a very unique state. If you see, before health sector reforms came, Delhi has a unique characteristics because the administrative leadership was with the journalist. It was your IAS bureaucrats rather than the technical personnel which adopted in 1947. As per the Bohr committee, the Secretary of the Health should have been the Director of Health Services only. But if you see all over the India, it is only the bureaucrats who are the Secretary to the Health. The Secretary of Health has always been a IAS officer. The Directorate of Health Services had generally been a clinician appointed by seniority in the system, and policy decision has been shaped by the political heads and the general administration. If you see, as per our regulations, rules, guidelines, Director Health Services is the technical head. But over the time, all these decisions for the health sector are being taken by the political and the bureaucratic heads. Promotion of private sector and features of new public health management can be seen since 1980s. That is, private sector is involved in various activities of the, especially in the tertiary care. Many incentives are given and many, you can say, subsidies are also given at the level they, so that they can strengthen their system. And on the other hand, there were cutbacks in the public health sector. DHS in Delhi has been a powerful organization. It was charged with the function of planning, provisioning and regulation of private health sector. But at the end of 1980s, the DHS was the controlling authority of medical services, Ayush, family welfare. But over the time in late 1990s, all these powers were taken away from the DHS and all the hospitals were under the secretary. Ayush system was under the secretary. There was a separate directorate of family welfare. There was separate department of public health. So you can see over the time how when there was an integrated DHS, how it was bifurcated and given the powers to the vertical system was created. During the 1990s, the situation of Delhi saw the opposite trend but on the other side, Delhi has done various other activities which were not seen in other states, because Delhi has opened number of new institutions coming up in the public sector, and the budgetary allocation was one of the highest in the Delhi. It has gone above 13% of the GDP also. Public health sector expanded with the opening of health center, providing basic health services to the people, new hospitals, new initiatives and schemes for vulnerable groups, expansion of health and family welfare department. It was found that there was a complex and dynamic process of health services development by the Directorate of Health Services in Delhi over the 1990s. That is not merely a linear move from the public to private services, but also increase the coverage in the public health sector. Even other components, if you see, public funds supporting the private sector was given. The government working with both public and the NGO sector. It adopted technocentric program strategies, increased medicalization, expansion of private sector, initiated charger or the user fees, staff on contractual basis and outsourcing of non-clinical services was done, and changing role of the technical and the administrative wing with the context that it will improve the management. Commercialization of public health services and corporatization of the private sector was also seen in Delhi. As a result, cutbacks, outsourcing in the form of contracting out public-private partnership took place in public sector, assuming that it will improve the public health system. Recruitment and doctors was done on the contractual basis. Approximate 200 doctors and 125 public health nurses, 200 staff nurses were appointed on contractual basis. There was a reversal of the contractual appointment policy. Doctors were appointed. Doctors have gone to the court and they were appointed on the regular basis. And even nurses have also gone to the court and they were appointed on the regular basis, the same who were appointed on the contractual basis. You can see how the reversal has taken place in this state. And nursing cadre continued denied of decision making. That is the biggest drawback still existing in the Delhi government. Directorate of Nursing was not created. PPP with NGO involvement in outsourced services, that is school health scheme and mobile health scheme was done. And public health nurses who were working in school health scheme and mobile health scheme, they were posted in dispensaries and hospitals without changing their designation and the job responsibilities. Situation of nursing in Delhi, just in brief, the post of Superintendent of Nursing Services was sanctioned for the supervision and management of nursing services as per the 1976 Gazette. Still, that post is vacant. You can see in 1976 that there was a vision about the expansion of nursing, and till date, we are in 2024. There is no post at the Delhi state level for the director of nursing or a deputy director of nursing or separate directorate. The seventh plan in 85 and 80 proposed the establishment of nursing cell in the DHS, but cell could not be established because a post of assistant director of nursing was not created. This post was sanctioned, but no one was aware about this post, and this post never got the filled up this post. Officers of the DHS interview stated that they were not aware of the creation of this post as it was never advertised. One of the CMO handled the nursing work as a part of medical branch or CME cell under. You can see doctors were looking after the nursing cadre and the nursing work in the Directorate of Health Services. Posts of public health nurses were created and filled for the first time in 1978-79. This was really a great achievement for Delhi because in school health scheme, nearly 53 public health nurses post was created and all the posts were filled. But unfortunately, there is no public health nursing cadre in Delhi. Since 1985, public health nurses recruited for school health scheme were utilized not only in the school health scheme, they have done a great achievement in various public health activities, like they initiated the work during disasters, immunization campaigns, training of health workers, training of teachers, state level programs, even in the implementation of NRHM in Delhi. PHN working in school and mobile health schemes, some of them were posted in dispensary. Unfortunately, their designation was not changed in the beginning and their job responsibilities were not given because there was no one at directorate level to look after the nursing cell. In 2005 and 6, the Government of India under the NRHM state that all state governments should have a separate directorate of nursing. But in 2005, under NRHM self took initiative to initiate the work of the Directorate of Nursing. At that time, no initiative was taken at the district or the state level because majority doctors and the bureaucrats were looking after the policy issues. No one took initiative. But NRHM nodal officer, although he was a doctor, he took an initiative. And in the plan document, 5 lakh notional money was given for the nursing cell so that in future nursing cell can be established. Government of India granted rupees 90 lakhs to Delhi to start a nursing cell. I was the part-time nursing consultant. We did our best. We have made the structure of the nursing cell, created the infrastructure, but I was not working in that department that time. And there was no nursing personnel who took the initiative to carry on this work so that we can establish the work because dominantly there was a conflict between the nurses who were from the education side and who were from the service side. In 2014, again, initiative was taken to establish Delhi State Nursing Cell under the additional director, given the responsibility by then secretary to organize induction training for new nurses recruited in the hospital. Nearly 1,000 new staff nurses were trained for 2 years. PHNs were deputed from school health scheme to work as a part-time with a part-time consultant. Skill training was organized for this, all the nurses in the Delhi. In 2016, infrastructure which was built for this nursing cell was handed over to some other department and files from the DHS of the nursing were transferred to the secretariat. One of the Directorate of Health Services, he said they have tried their best to convince the secretariat, but till date, the nursing cell is not being established. One of the reasons the technical cell do not want to give the control power to the nurses so that they can control their own cadre. Secondly, nursing professionals did not come together to fight for their rights, and no nursing person in the directorate were interested to take up the higher responsibilities. Although in 2016, again efforts were taken by then Secretary and the Director Health Services to establish nursing cell, but there was again confusion and among the nurses, and there was a conflict, and result was zero. In 2005, my conclusion is in 2005, the launch of NRHM in Delhi focus was again on basic primary healthcare services to people who are, the services can be accessible, affordable and cost effective. Although the change in political leadership changes what is happening in the ground level. If you see in Delhi, many dispensaries were converted into polyclinics and the mohalla clinics were opened. So, initiative after my study, which I presented to the government of Delhi, skill training for nurses was started. That is, guidelines were made, protocols were made, procedure checklists were made, and trainers were trained, and the hands-on training was done with the thing. If nurses will perform, they used to be given the training, demonstration, re-demonstration by nurses, unless they had 80% of proficiency, and in case they are not present on the day, no certificates are being issued, they will repeat the training if they miss any session. PHNs were posted later on in the district and the state level, so that they were part of the NRHM and they were given the higher responsibilities, and people were really very happy. Even the administrators were very happy. Then Delhi Nursing Cell, although the structure was made, very unique structure was made for the Delhi, and all the guidelines were in place. Hope in the future, Delhi Nursing Cell will take the shape. Even the standing orders for the public health nurses were made so that they can work in the clinical area. So these were some of the achievements which I could do even after my study, because the government has given me permission to conduct this study. It was very easy for me to approach the government so that they can, you can say, implement my findings of my study. So that is my achievement of my study, and it is very different study, which I should say. It is just one part of my study which I am able to present today. Thank you so much.
Beautiful, beautiful. Very challenging study. It's really challenging.
Thank you so much, ma'am. I will show you my conceptual framework if I can, just 1 minute, which I could not show you.
I think you should continue more till the directorate, established.
Ma'am, I was actually with the change of
continue
government.
that,
Ma'am, with the change of government, many things changed. Ma'am, this is my conceptual framework. If you can see, conceptual framework of Directorate of Health Services, how the external factors have influenced your political head, administrative head, and there was collaboration linkages. It's a very complex system, Delhi health system. So you can see I have studied all the linkages, external linkages from these arrows and the internal linkages. And there are 3 aspects. What I have taken was policy, planning, provisioning and regulation. And these were how it has impacted even our nursing services. So this was a complex conceptual framework which I had made keeping in view the systems approach. And just my last document which I wanted to show was my data collection one, methods of data collection. You can see the process of data collection from the year wise. It started in 2001 and 2. It has gone till 2010. It was so extensive study that it took 8 years for me to conceptualize this study. And all the things were done. And these are the details, how I have interviewed the person, where all I have visited. Everything is there with timeline and all these things. I just wanted to say why it was such a extensive study and took so many years. And I was really very proud in JNU. All over the India, there was no study available of this kind. I am the first scholar from JNU who have studied the health system of any country. And based on my study, various other scholars in JNU will study, and then over the time we will compile all the state studies. So this was my small achievement for the public health sector. Thank you so much for the opportunity.
Very good, very good. Dr. Nirja, did everybody cooperated for the interview?
Yes,
Or
ma'am.
there were some constraints?
No, ma'am. I never had a problem. Why I never had a problem? Because I worked there for 22 years.
Okay.
So that was a very part. All the doctors, I should say, they were so cooperative. I had 146 tables with the government data in my thesis because they have given me all the reports, whatever they had available in the public forum. And
Very good.
yes, even when I was writing my chapters, I left DHS, still they cooperated with me. Whatever information was missing, I could get everything. Even Director Health Services used to give me interview. He used to say, if someone is creating problem, you come to me, I will give you. They have given me a blanket permission without putting any condition on me.
Beautiful, beautiful.
Ma'am, I should say one thing at the end. If you work sincerely, no doctor will block the way. This is my achievement of my life, that none of the doctors ever have blocked my way. Rather, they had helped me to conduct my study.
Good.
Thank you, ma'am. Thank you for your wonderful study, ma'am.
Thumbs up.
Thank
Yeah.
you, ma'am. Thank you so much.
Ma'am, may I?
Yeah, please.
Ma'am, first of all, a big congratulations to you that you have taken a really a need-based like mirror image for our country health system being a part of the healthcare team. I just want to ask one thing, ma'am. When you
Yeah.
were doing your study,
Yeah.
that time the concept of ASHA worker and this community health officer concept was there in the flow?
ASHA started. ASHA 2005 NRHM it came when I was in NRHM cell.
Yes.
By the time Delhi has adopted, it was already 2007 and 8. Delhi has adopted very late all these things.
Okay, ma'am, but
Actually,
there
why?
was...
Just let me finish. Why? Because Delhi was not a rural area. Delhi is an urban area, metro city. So Delhi government took time. Although we have initiated NRHM in Delhi in 2005, it was launched by Shrimati Sheila Dikshit ji in 2nd October 2006. But it took a little time to implement it. But they had a very good advantage when the National Urban Health Mission came. Already in the Delhi, the basis, the background work was ready, what our team has done.
Okay. But ma'am, it was there in IPHS standard 2012 when they were not having a directorate post, or this public health cadre was on senior grade was not
Madam,
created.
there is in Delhi, there is no nursing cadre, there is no nursing directorate, there is no public health cadre. ASHA and ANM are not part of public, they are not nurses, they are subordinate associate nurses. So actually there was a move for public health cadre, but that was only made for the doctors, not for nurses.
Okay.
Yeah.
So, ma'am, any further this thing, Miss Hope is there that there will be light of hope that cadre will be.
Acha, okay, I will tell you, we have gone through TNAI also. TNAI took me to meet all with the new government, which is at present in the Delhi. But unfortunately, they are not very positive towards nursing.
Where will be again a big query.
Yeah, see, now I am not working in Delhi government. People who are working there has to take initiative, because I already made base Even the daily cell structure is ready, which was approved by the secretary. And I took so much of effort. I will not name the person whom I brought in the directorate, but again, we should remember nurses do not work together. There was a conflict between from people in that team from nursing education and from the nursing service. And then
Very
the
true.
people take advantage of that conflict. And due to that conflict, she was removed from the directorate. It was a big setback. And even
Yeah.
one of the very senior person told one of the director, why you are taking Neerja Sood as a nursing consultant? She is not working in Delhi government now. He said, it is our choice whom I take. I will not name all these people. These are the causes because nursing people never come together. We only think of ourselves. Although I was given the option that I should come back to Delhi government, but I said no, there are people who can take over this. So you can see, we also have to see why we fight among each other and why we have ego problems in the service, education, public health.
Very true. Very true. And Alkaji, you asked about the community health officer. That scheme was going on and got implemented in the year 2021. And now, of course, in Delhi and various other states also, the community health officers are appointed now. I think that has been started.
Yes, ma'am. Actually, ma'am, Delhi government, when there are two parties from different political backgrounds are there are many conflicts. I have with the TNA gone to LG also so that we can establish Delhi nursing cell. But they said till that time, AAP government is there, BJP cannot do anything. We have gone to the MPs, MLAs also, but there is so much of political conflict that someone has to, even we have approached the Delhi Nurses Union also, but there are many political and the bureaucratic things. Delhi Nursing Cell, the technical recruitment cell is a very strong body because maximum more than 3,000 nurses are there. They don't want to give the control of nurses to nursing cell. That is also one of the reasons because their bureaucrats are sitting there. They don't want to give up the control of nurses.
Ma'am, thank you for a wonderful study, ma'am. Now I would like to take a feedback from the resource person, Dr. Geeta, ma'am, and Ashiya Kurasi, ma'am.
Yeah, I think Neerja ji, you have done a wonderful job, and it was a very, very challenging study. And it's good that you have got the cooperation from so many people, and so much of modification has been done. Of course, it is in their mind, Do you have, highlighted some of the things, which they have to do it,
Yeah.
And this is now, I think, time the nurses should occupy the political positions.
Yes.
Unless the nurses are in the political system, nothing is going to
Yes.
change because you find everywhere in the list, all the occupations will come. The nursing profession is missing.
Yeah.
I will tell you, yesterday I was filling the visa form for Canada. I was seeing that where should I tick mark, all the big list was there of all the occupations, but nursing occupation was missing from there. I got wondered. I said, where should I mark? I can't mark others. This is what is happening. So I think somebody has to take this, some political positions in the, government, and then only I think we will have some improvement,
I
in
agree.
our nursing cadre,
Ma'am,
Nobody
both
else is
yes.
going to think for us.
Yes.
We have to think about ourselves, and we
Yes.
have to fight for ourselves.
Yes.
Yeah.
Excuse me, we have to keep the time in mind, 20 minutes for each person, please.
Yes, ma'am.
MC, continue, please.
Yes, ma'am. Ma'am, Dr. Geeta, ma'am, any feedback, ma'am?
Congratulations again, ma'am, for such
Thank
a
you.
thoughtful and need-based study. And I hope, ma'am, your contribution will be there again to follow up the upcoming health reform system. But, ma'am, one thing to say, today we are proud to see in our country, nurse practitioner has come up
in midwifery, maybe in the form of just a teething effort. But let us see, ma'am, that how they come up to increase the maternity quality care in India. Ma'am, once again, congratulations
Thank
to
you.
you, and yeah,
Thank
thank you.
Thank you so much.
Congratulations.
Thank you.
Khanna ma'am, feedback ma'am. Anything you want to give feedback ma'am? Khanna ma'am.
I am just saying congratulations, kudos to her for this long hours of experience and years rather. And we should continue with Rita ji.
Thank you, ma'am.
Sure.
If with permission, I will take leave because I have a session. Thank you so much.
Yes, you
Thank you.
already requested.
Yeah. Thank you so much.
Thank you.
Now I would like to call introduction of second today's speaker, Dr. Professor Dr. Rita Lakhani ma'am. Madam is currently working as principal Mangala Institute of Nursing Education, Maharashtra, and former principals of DY Patil University School of Nursing, Nerul, Navi Mumbai. And Madam is a member of various professional organizations, Vice President of the Oncology Nurse Association in India. Madam is having a 23 years of professional experience in various faculty positions, including critical care clinical experience. Madam's major achievements are included received many awards, of which gold medal at MSc Nursing, and received the Bharat Vidya Shiromani Award and a Certificate of Education Excellence for outstanding achievements, and remarkable role in the field of education in December 2015 at International Institute of Education and Management. Certificate of Outstanding Contribution in the field of education during the Asia Education Summit and Awards 2016, and Best Principal Award in 2020 by Excellent and NOI. Best Teacher Award 2023 by TNI Maharashtra State Branch and NTI 2023. And about publications, Madam has received a first prize in teachers category amongst all faculties at Maharashtra University of Health Science for research presentation during the Avishkar Convention 2010 and 2015. Madam has presented over 20 papers in international and national journals and 9 book chapters. Received 3 Best Paper Presentation Awards, and Madam has a research guide for 2 international students and delivered more than 40 talks at various forums. Now, I would like to call Dr. Professor Rita Lakhani Madam Ji to continue the presentation.
Thank you.
Ma'am,
Thank you,
over
Doctor,
to you,
for that humble presentation. Will it be possible for me to share my screen? If you
Yeah, ma'am, please. Yeah, ma'am.
yeah, if you stop sharing, then I'll be able to share it.
Yes, ma'am.
Yeah, so I think it's visible now.
Yes.
Yes, ma'am.
Yeah, thank you so much. At the outset, I thank the NSS team for giving me this opportunity to present my research. And am I audible?
Yes, ma'am.
Yes, you're audible.
So the title of my research is Effect of Aloe Vera Gel Topical Application on Radiation-Induced Mucositis in Head and Neck Cancer Malignancy. It's a double-blind randomized clinical trial in Mumbai in India. And I thank my guides, Dr. Shirsagar and Dr. Chedda, for taking me through this journey. Yeah, regarding the magnitude of the problem. So when we see head and neck cancer, over 2 lakh cases of head and neck cancer malignancy occur each year. This constitutes 1/3 of all cancers, in contrast to 4 to 5% in the developed countries in our country. It accounts for 1/4 of male cancers and 1/10 of female cancers. The high incidence of oral cancer is attributed to widespread habits of tobacco chewing and quid, which is very predominant in our country, and smoking. Poverty, illiteracy, advanced stage presentation, lack of access to healthcare, and poor treatment infrastructure pose a major challenge in managing these patients in our country. So we have major 4 sites of head and neck malignancy. It's a heterogeneous disease. It's in the oral cavity, it's in the pharynx, it's in the larynx, nasal cavity, sinuses, and the glandular areas. Mucositis is one of the most common acute and debilitating complications which results during intense cytotoxic therapies, including radiation therapy during head and neck malignancy. For head and neck malignancy, radiation-induced mucositis, I would be using the short term as RIM. So RIM occurs in about 95% of patients treated with radiation therapy. Every patient undergoing altered fractionation RT for head and neck malignancy develops mucositis. Radiation-induced mucositis of grade 3 and 4 have been recorded in 56% of the head and neck malignancy patients treated with RT. So this is just a brief run-through of the various researches that I went through. The impact. So when we look at the impact of RIM during radiation therapy, some patients, it is asymptomatic, may show intolerance to spices or hot food, burning type of pain. Patients' oral intake is reduced, they become nutritionally deprived. There is taste alteration, secondary bacterial and fungal infection, swallowing and speech abnormalities, systemic effects like fatigue, anemia, anorexia, cachexia, neurocognitive alterations, and depression. Grade 4 mucositis, it leads to ulceration, necrosis, bleeding, and leads also to interruptions in radiotherapy and admission to the hospital. Current practices for managing radiation-induced, for managing RIM, radiation-induced mucositis, it has been a subject of interest for the past 30 years, yet the progress has been limited. Is something that I want to impress upon every person who's listening to my presentation. The current care of patients with mucositis is essentially palliative, and it includes oral hygiene, topical mouth rinses, topical anesthetics, non-irritating diet, opioid analgesics, treatment of coexisting infection, and benzodiazepine low-level laser therapy, and or biological response modifiers and growth factors. So we have understood up till now, RIM is going to be an important problem in all our patients who are undergoing radiation therapy. And this is what is the care that's there today. Use of aloe vera. There is no universally accepted medical solution for prevention of mucositis. Aloe vera contains 75 potentially active constituents, vitamins, enzymes, minerals, sugars, lignin, saponins, salicylic acid, and amino acids, with established clinical use for various skin conditions and non-communicable diseases. It is easily available and at low cost. Patients often self-medicate themselves also. Timely nursing care and instructed home care will equip the patients to care for themselves and increase quality of life, as it is the nurse who assesses RIM and its impact. So my statement of problem, therefore, is RIM is a problem for all patients undergoing radiation therapy for head and neck malignancy.
Chat box
Please unmute yourself.
मैं पहले करके हटी हूं, होया नहीं हैगा. गुड मॉर्निंग लिख के ना लिखना.
Thank you. RIM is a problem for all patients undergoing radiation therapy for head and neck malignancy. RIM has an impact on patients' well-being, nutrition, because of continued treatment. Let's remember this treatment goes on 6 weeks minimum, can extend to 7 weeks also, 5 days in a week. There is no consensus about treatment for RIM among oncology care team. I, therefore, decided to examine this issue through a clinical trial using local application gel of aloe vera in view of its healing potentials. The purpose of this research paper is to assess the effectiveness of topical aloe vera gel in reducing the magnitude of progressing RIM during the therapeutic course of RT in head and neck malignancy using specified outcome parameters. The objectives of my study were: first, I wanted to compare the onset of occurrence of RIM in 2 groups, that's group A and group B, but all the respondents were receiving radiation therapy. Second is to compare the severity of RIM in the respondents on aloe vera based on the primary and secondary assessment criteria. Third was to compare the difference in change in RIM due to the intervention among the respondents with selected variables as age, gender, history of smoking, and the RT dose. My conceptual framework was based on Virginia Henderson theory. And Virginia Henderson has got 14 components. The first 9 components are physiological and they are impacted by RIM. So for example, eating, breathing, eliminating, dressing. The 10th and the 14th are psychological aspects of communicating and learning. The 11th component is spiritual and moral, and the 12th and the 13th components are sociologically oriented to occupation and recreation, which are also impacted during radiation therapy. Operational definitions. I'll take only significant operation definitions over here. So RIM, radiation-induced mucositis, refers to the scores that the patients obtained on the WHO scale of grading oral mucositis and the pain scores as obtained on the FACT-HN scale. Severity of mucositis was also operationalized to include the secondary outcome criteria. So I have taken WHO scale only because it was used in my clinical area. There are more scales too. Topical aloe vera. This is something very significant in my research. So it refers to application of 10% aloe vera gel, which was supplied to me by BioGreen Company Limited. It was supplied to me in tubes of 30 milligrams as 2 tubes, tube 1 and tube 2, to be applied over the oral mucosa 3 times a day, every day, from the start of early signs of mucositis till the termination day of RT. None of us knew, neither me, which tube was having aloe vera, which tube was not having aloe vera. So one of these tubes had aloe vera, and aloe vera is prepared in a base gel. The base gel has got glycerine, so glycerine is also going to have effect. Therefore, in one tube, I had the base gel only, and in the other tube, the base gel had a constituent of 10% aloe vera. My hypothesis. Respondents with head and neck malignancy undergoing radiation therapy receiving aloe vera gel will have reduced grades of severe RM scores on the terminal day of radiation therapy at 0.05 level of significance. The delimitation of my studies were, this study is delimited to assessing RIM in respondents only after its onset and therefore does not aim to analyze its preventive aspect. This is simply because I started aloe vera on the day when I found the early signs of RIM. I did not start on day 1 to see which group in which group the preventive aspect was there. The study does not include a no intervention group because I had just 2 groups. In one group, I was giving base gel. In the other group, I was giving aloe vera and the base gel. This research was delimited only to the effect of aloe vera in all patients and did not compare groups undergoing other different treatments. Assessment of RIM was delimited to only oral mucosa because other areas are difficult to assess. The period of main study was from November 2014 to October 2015 in a JCI and NABH accredited Fortis hospital, and the local guide was the head of the Department of Oncoradiotherapy. The research design, as I have very clearly said, it's a double-blind study. So both the tubes were unknown to me, anyone in the clinical area. It's a clinical trial, a block randomization. Control group received only the base gel. It refers to all patients diagnosed with head and neck malignancy and scheduled to undergo RT with or without concomitant chemotherapy at Fortis Hospital. Now let's remember, all the patients who undergo radiotherapy can go concomitant chemotherapy, which is once in a day during the radiotherapy session, which is an additional thing along with the radiotherapy. 110 patients met the inclusion criteria. The final sample was 51 in A group and in group B was 49. I did not know till my revelation which group was the experimental group and which group was the control group, whether it's what group A or group B. Lehes formula was used to calculate the sample size for a power of 90% and a two-sided significance level at 0.05. So the inclusion criteria for my sample was above 18 years. Above 18 years, they should have normal mucocyte baseline. They should commit to the schedule of assessment, able to read and write, because I had 2 tools where they had to self-report. And they should sign my informed consent form. At least 1/3 of the oral cavity mucosa should be included in radiotherapy because it is a heterogeneous disease with 4 areas. With the minimum prescription of fractionated radiation dose of 58 grays, which was delivered over more than 25 fractions over 6 to 7 week period with or without concomitant chemoradiotherapy. KSP, that is Karnofsky score performance, which shows how much the patients are independent, was kept at 70% and above. The exclusion criteria was patients who had earlier undergone prior radiotherapy or chemotherapy because they tend to have early mucosa breakdown. HIV infections, DM, and hypothyroidism, or any patients receiving immunosuppressive drugs were excluded. That's my block randomization design, because I had many variables which I had to block in my sampling. So I took one arm, which was CCRT, that's concomitant radiotherapy. I'm sure the listeners would agree that if a person is undergoing chemo and radio, would develop mucositis earlier versus only receiving radiotherapy. So there was group A and group B, 2 blocks which were created. And of course, in each of this, the other 3 blocks were the same. So oral cavity and oropharynx, larynx and hypopharynx, nasopharynx, because naturally the mucositis that would develop in oral cavity would certainly be more than a person who was undergoing radiation therapy in the nasopharynx. So that was my block randomization design. Ethics. After the university cleared my research, Fortis Hospital, I had to do at least 3 presentations to get my ethics clearance from the Fortis Hospital. Patient information sheet was prepared. It was implemented using a PowerPoint presentation, and informed consent was taken. I had the following tools. So the first component of the tool, which was an interview schedule, included the biographic data of the respondents, what kind of tumor it was, the RT treatment, how much dose it was in terms of gray, the characteristics of the patient, need for analgesics, need for antibiotics, need for antifungals, need for anesthetic. So I said the patient would get pain. So normally the patients are started on analgesics. They are put on antibiotics because they get fungal and other infections, and anesthetic drugs to relieve pain. Hospitalization, in case if the patients go into severe grade and they are not able to continue with radiotherapy or chemotherapy, hospitalization is required. In case if this situation is there, then even nutritional support and RT interruption. I had 2 tools, OMWQ-HN and FACT-HN. Both are quality of life tools, and I also had a pain score which is incorporated into it. An observational tool was recorded to see the WHO assessment of oral cavity, weight loss, and KPS. KPS was only to see how independent a person is. This was to ensure that the patients are able to comply with the research obligations and it's not a burden on the caregivers. This is the OMWQ oral mucositis score, which had 12 questions and 12 questions in various areas of the oral cavity to see how functional they are. It's a commercially available tool, but I've still sought permission from the authors to use this tool. FACT-HN, Functional Assessment of Cancer Treatment. Again, it comprised of 4 subscales and had 26 items, and all these 26 items were assessed once in a week. Overall, the highest score shows a better QOL. This is a WHO oral mucositis grading score, which was done again once in a week. The reliability of all these tools. So when I had to weigh my patients, I ensured I did a test-retest stability on weekly basis. This scale is kept in the radiotherapy department. The reliability and validity of FACT-HN is established at 0.8 to 0.89 in various Indian regional languages also. The reliability and validity of 12-item OMWQ-HN questionnaire is established at 0.84 to 0.89, and WHO is a standardized tool. Inter-rater reliability was done with my clinical co-guide, HOD, of the Onco-Radiotherapy department, and it was at 0.9. So this is my protocol. When I met my patients on the first day, I explained them, I screened them, of course, I explained them what is the protocol and what all they have to comply in terms of this research. So on the day 1, I did I collected the biographic data, checked their weight, checked their KPS to see how independent they were, and I implemented the OMWQ-HN and FACT-HN version and the pain assessment, including WHO. On weekly basis, I did the WHO scale of mucositis, OMWQ, and FACT-HN. As I've said, this is quality of life. From the case sheet, I took the onset of occurrence of RIM. So I went on a weekly basis to see my patients in case if I was not there. occurrence of RIM was written only by my guide because she is the head of the department. And she does this for all the patients. She did not do it only for my patients. So this is a routine. She records it because this is an outcome criteria at FHL when patients develop mucositis. Then the need of specified drugs, the nutritional onset, the nutritional support and interruption of RT is also recorded by her. The assessment on last day, again WHO, weight and the 2 QOLs. So this is the overall flow. I got an IRB clearance at Fortis. I screened 157 head and neck cancer patients as per the eligibility criteria. 47 were excluded for various reasons. 110 patients met the inclusion criteria and consented to participate. PIS was implemented. ICF was also collected. It was done in the ROD. It's an emergency department in the radiation department, which is an empty room. Normally, we don't have emergencies. So this room is created as a standard for NABH and for NABH criteria, but nobody uses it. So it was a very comfortable room for me to take my patients aside and explain these details to them. Normally, all the patients get health education from the clinical nurse, which continued. So I did not intervene into the protocol of care that is being undertaken in the department. Block randomization was done as per the site and as per the CCRT. So they were randomized into aloe vera and the base gel groups, and treating physicians treated the patient in the 2 groups no differently than other patients. The researchers, study area, clinical personnel, and the patients were all blinded. None of them knew which tube they were getting. The data was collected using the interview schedule and the observation tool. Group A, 1 got admitted for RT, then non-compliant because he got admitted. That was very severe. So it was interrupted RT. 2 left and there was 1 death. In group B, 1 got admitted because the patient was nutritionally deficient. 2 + 1 were non-compliant and 2 went LAMA. So total 100 respondents completed the study. Group A had 51 and Group B had 49. A pilot study was undertaken on 10 respondents and VAS scale was removed because pain was already a part of the QOL tools and there was a repetition. So the patients were not comfortable in answering. We removed that. QOL tools, instead of self-reporting, because I felt some of the patients left the items, I interviewed the patients. And there was no significant difference found in the RIM primary and secondary outcomes, which I just discussed with you all. The findings of the study. So it's very interesting to note that I had no significant difference in terms of gender, in terms of age, in terms of education status, but there was a significant difference in the history of smoking. So we will note that there were more ex-smokers in the experimental group than the control group. Now the experimental group and control group has come in because after data collection, during analysis, I invited what does tube A and tube B stand for. It is also interesting to note that there are more male members and it is there in later age. This problem comes in later age than in early age. With respect to tobacco chewing, again, there was no significant difference. So both the groups had equal number of tobacco chewers. Alcohol consumption, no significant difference. And KPS was, since it was standardized, it was, again, there was no significant difference. It is significant to note that there were around 54% people who were alcohol consuming. So there were 50% almost people who were not consuming alcohol. So alcohol was a problem in causing head and neck, must have been a problem in causing head and neck cancer, but it was at 50%. Let's look at the other analysis. So the primary sort of malignancy, most had tumor in the oral cavity as compared to the other 4 sites that I had mentioned. They had well differentiated to moderately differentiated squamous cell carcinoma, but both are non-significant in the 2 groups. With respect to respondent stage of malignancy and the nodal staging, so we will note again, there is no significant difference in the 2 groups, but let's note that in the tumor staging, was T2, which was predominant in both the groups, and the nodal staging was again N1, which was predominant. NO, again, lesser number of patients are coming. We are not able to catch our patients earlier. Regarding the RT dose that was received, again, there is no significant difference in the two group. Even in fractionation RT dose received, there was no significant difference. So on an average, the experimental group received 33.8 fractionation days and the control group received 32.5. There's a slight increase in the fractionation days of the experimental group, but it was not significant. In terms of concomitant chemotherapy, cisplatin was used at 40 milligram per meter square, IV every day, every week for 6 to 7 weeks. And we will note that more number of patients received it in the experimental group than the control group, but there was no significant difference statistically. Respondents who underwent surgery for the primary tumor, more patients underwent surgery for the primary tumor preceding the current chemotherapy in the experimental group than the control group, but yet it was not statistically significant. The KPS score, again, were not statistically significant. So thus, both the groups did not differ significantly in terms of age, gender, educational status, alcohol consumption, KPS, tumor characteristics, treatment characteristics, CCRT, and surgical resections, except for history of smoking. So both the groups were equal when we started off in analysis. As per the objectives of the study, the findings, in my study, all patients developed RIM. And it is important to note that the average onset of occurrence of RIM was 17.5 in experimental group and 16.8 in the control group, and it was statistically significant. So when I say it was statistically significant, patients developed RIM earlier in the control group than the experimental group, though most of the characteristics were standing strong in terms of developing RIM for experimental group. Let us also note, I don't have any hand in this because I have not started aloe vera before to see the preventive aspect. So this is a normal phenomena that happened. Fine. So when I look at RIM grades in experimental group and the control group, the experimental group developed RIM. We can see in the third week, I have highlighted with red. So 11.8% developed in the third week, 16.3% developed grade 1 mucositis in the third week. And as you see, from there onwards, the aloe vera comes in, the intervention comes in. So 100% developed it in the first week in both the groups. And then you see, then there's a statistical significant difference, 98%, 57% in the control group, moving on to 83%. And when you look at the control group, grade 4 was also there in the last week, 2%, and 76% in the grade 3 was there in the last week, whereas there were no patients in grade 3 in the control group, 27% with grade 3 mucositis and 64% with grade 2 mucositis. So mucositis grade on the last day, it was a significant difference. Greater number of respondents developed severe RIM in the control group than the experimental group. Again, when you look at the severity of the, Again, when we look at the severity of RIM in both the groups, it has been seen that the severity of RIM in both the groups was not statistically significant till day 22, but after that it was statistically significant, which is showing the effect of aloe vera. The oral pain, very interesting to note, which I've got in my study, which I did not get in any other review. In my patients, pain started first. So there were patients who did not have mucositis, but they had pain. And it is also interesting to note that the pain continued till the last day of radiation therapy. Now, the grades of RIM and pain, this is what I was trying to show in my previous slide. Though the patients have demonstrated pain earlier than RIM developing, yet all the patients complained that they had pain till the last day. It is also significant to note that the pain was comparatively less in the control group in the experimental group, but that was not statistically significant. The use of drugs. Analgesics was used. Less number of respondents needed it and needed it later than the control group. All antacid anesthetics and antifungal. And antibiotic both did not differ in terms of requirement. So in terms of antibiotic, both the groups did not differ significantly, but in other, they did differ. Hospitalization. So it was not significantly different between the experimental and the control group, as I have reported earlier. FACT-HN, let's remember, increase in score was significantly higher in the experimental group from 5th week onward. Prior to 5th week, it wasn't significant. So it is showing the effect of aloe vera. Again, OMWQ-HN score was significantly higher than that in the experimental group. The higher scores show more problem. So here again, the significance was shown at the latter weeks. With respect to comparing the demographics with RIM to see whether any demographic feature is causing an impact on the RIM, again, there was no significant difference in terms of age, gender, education, and history of smoking, both in the control group and the experimental group. Since all the p-values of association of demography with the RIM was large in both the groups, there is no evidence for null hypothesis. Statistical significance. After analyzing the control for age, gender, radiation dose, history of smoking, the researcher found statistically significant difference between aloe vera and base gel in RIM scores. Pain scores were not significantly different between the two groups. Thus, in my discussion, I would say the RIM scores appears to be favorable in the experimental group than in the control group, as the respondents in the experimental group reported comparatively lower grading of RIM and lower maximal severity grade. This is in line with previous researchers where Su C.K., Mehta, Puttavipong, Emadi have shown that aloe vera, in addition to a standard prophylaxis regime, reduce the incidence and severity of RIM. Pain outcome is not in line with the study conducted by Greg Arnold, which was done in 2013. Aloe vera solution was used 3 times per day orally, consisting of aloe juice, which produced complete pain remission of mucositis in 31.2% of the 32 cases after 6 weeks and in 61% of the cases after 12 weeks, compared to 17.2% and 41.6% of patients in the placebo group, respectively. Let's remember, Greg Arnold, as I've said, used aloe vera as a consumption solution, whereas I have used it as an oral as an application gel. It is interesting to note that though I have used it as a local application, the pain was not reduced, but Greg Arnold demonstrated the pain reduced with an oral consumption. Greg used it as a consumed one, and it has shown as an effect on pain, but not on oral mucositis, whereas I have used it as an oral application. I have got remission, lesser grade of oral mucositis, but I did not have any effect on pain. The limitations of my study. The respondents' compliance could not be validly monitored, but on an average on the 13th day, the tube had to be replenished. The endpoint of the study was the termination day of RT, since there were referral patients and the patients then went back to the primary physician. I would have loved to continue to see when RIM reduced after discontinuation of RT. The implications. Because aloe vera's promising clinical anecdotes, low cost, and popularity as a herbal supplement among general population, I recommend use by nurse clinicians in the routine care of patients developing RIM and head and neck malignancy during RT. Through a protocol, it has to be applied in nursing care in oncology hospitals by including it in the manuals of nursing care, just as it is included in manuals of skin care. Conclusion. Results confirm the risk of radiation toxicities in 100% patients. Aloe vera gel was safe, well tolerated, and effective in delaying the intensity of progressive RIM during the course of the respondent's therapeutic RT. Aloe vera is readily accessible and of relatively low cost and should be considered as a good alternative agent for treating. I acknowledge NSS for permitting me to do this presentation, and all the other people who have contributed towards this research project, including BioGreen Company and my patients. These are my references. And I thank you so much. If there are any questions or concerns, I would love to address them.
Thank you, ma'am. Thank you for our elaborative session, ma'am.
Madam, you have done an excellent job, wonderful job, because nobody was speaking, so I thought, let me speak, And I think your study has given the scope for the further research, in using the aloe vera in, diabetic foot,
Yes.
And
Yes.
if somebody can take the study on using it on bed sore ulcers, if it's so effective, for the mucous membrane of the mouth after cancer. So I think the further studies you can, or anybody can take on diabetic foot, because I have done the study on using honey on the diabetic foot, and the results was excellent, and we are our AIMS surgical department now is following that, use of honey, for a dressing for diabetic foot. So I think we can use this, we can take up this study on effect of aloe vera on diabetic foot and, bed ulcer, bed sores. That's all.
Thank you, ma'am.
It was a wonderful study,
Thank you.
Madam,
Thank
may
you.
I? First of all,
Thank you, ma'am.
congratulations,
Dr.
Dr.
Geeta, ma'am.
Geeta. Yeah. A very well presentation, and your all your well chosen research methodology, Dr. Rita. I must congratulate you.
Very.
And
Thank you.
and those tables were self-explained, that everything was so clear, and your concept of your presentation. So great achievement for that. I have just small one or two queries. That number one was regarding the tool you have taken on, one tool on functional well-being, correct? And the other was on quality of life. So I was just wanting to know the component of the tool were having some resemblance, like on functional well-being, 7 items. Or wo jo WHO quality of life, I think you have taken the tool. So they may be having the same questions, or it were different.
No, they were all different. So when you look at FACT-HN, it is talking only about the functional aspect of the oral cavity in terms of the oral function, whereas the other was talking about the entire overall effect on the quality of life. The simple reason why I took two, because I based my research on Virginia Henderson's theory, where I wanted to touch upon the 14 points, and I wanted to very clearly show in my research that it is just not the oral cavity that we must pay attention on. It is the other aspect of quality of life which was there in OWMQ HN tool.
Okay, thank you. And second one, my query is that all your patients who were receiving 6 weeks of the tube A or tube B, whatever, they all were hospitalized, or in between they had gone for leave and then came back. Just
No.
query.
Yeah. So, ma'am, when you look at radiation therapy in head and neck cancer patients, it is given over 6 weeks period. They come in the radiotherapy department, so they are scheduled for a given time. The radiotherapy barely goes on for about 4 to 5 minutes. The amount of grays that have been selected, fractionated grays that have been selected, that has been given to the patient, and the patient comes out, patient walks in, patient walks back home. So every day they have to come 5 days in a week for 6 weeks on a scheduled time to take the RT. So this application, whatever care is given to them, is to be done by themselves. So if they have to do it, I wanted to see the KPS score is higher. If the KPS score is lower, then it is the caretaker has to do it, and the caretaker may not do it. But if it is me as a patient, I would love to take care of myself more to prevent problems.
Mhm.
Thank you so
That
much.
is-
And one more small query, whether the two patients were on normal feed or they were on gastrostomy tubes, usually because weight loss was one criteria which you have taken.
Perfect. So I make myself very clear. I had delimited my research very, very clearly. I wanted to just concentrate on the effect of aloe vera in radiotherapy patients on their rim. So once my patients moved out of that scheme, I did not follow them up. Now, at a personal level, I did follow them up because they were admitted to the Fortis Hospital. So all the patients, once they develop nutritional problems, I mean, the rim is so severe that they're not able to orally take, then they are admitted and there is a weight loss. There is definitely a weight loss because of that. Now, if you go to see, I have told you there are about 2 and 3 patients. Both these patients, when they were admitted to the hospital, they were given RT feedings. We do not go on developing, creating a stoma. That's our philosophy. So we will try and anesthetize the patient, gradually introduce the RT in the patients and try and give them the feeds, because the problem is just to cross that area in the pharyngeal and going into the esophagus. Once that area is crossed, the RT goes in smoothly and then the patients can be fed. So all the patients were on RT. There was one patient who refused RT and said that let me start taking we have very good nutritionists. So they prepared some kind of a kanji for this person so the person could swallow. So one person was still on oral feeds, the other went on RT feeds. But that's not a
Yes,
part of my research, so I've not reported it.
Thank you,
Okay.
ma'am. That was out of my
Thank you.
curiosity. It was a very,
Yeah.
yeah, thank you. Thank you.
Dr.
Thank you,
Rita,
ma'am.
what type of sampling technique you have chosen? Is purposely sampling or random sampling? Because you have
No.
taken the control group also.
Yeah, so I have called my group as a control group. My ethical committee at Fortis Hospital was not permitting me to not do anything on the control group. They said, we will not pass your research. We will not allow you to do, because today ethics has widely grown. They say you cannot just take a control group and use them. So they said, you must do something. And it is they who gave me the idea that the base gel also has effect. So why don't you remove that, create a base gel and use it for the control group, because they also will be happy that something is happening on them. That is one thing that I want to clarify, that though I have used the word control group, they are not truly control group.
Okay.
Now, regarding my sampling design, I have made it very clear that I have used a blocked design. Now, in this block design, I know that when I have to take various sites, there is an effect on the site and there is an effect of the radiation dose. So therefore, I had to block randomize them. I had to screen all the patients who came in the hospital. If they fitted into my criteria in the block randomization and they were agreeing to come in, we have
Okay.
taken them.
Okay. One just simple small
you, ma'am.
question I would like to ask about, what was the composition of that base gel?
Yeah, so
Is
BioGreen
glycerin?
is
Yeah.
no. So BioGreen company was very clear when I started with my research. We will not reveal anything about our tube to you, but we will support you in the research. We do not want our name to be propagated, was my condition on them. I mean, I told them through this research, it should not happen that you start propagating it. So the terms were very clear. Now, they did not reveal to me what is there in the base gel, but they said, understand that whenever any tube is prepared of a given percentage, it has a base gel. And that is a constituent which gets slightly modified in different companies. So we will not reveal
Okay.
our.
Okay.
So that was
Okay.
very clear
That's
at the
it.
beginning, and I continued honoring that contract.
Okay. Thank you
Yes,
so
ma'am.
much. Thank you so much. And congratulations for the beautiful presentation.
Thank you, ma'am. Now I would like to introduce our third today's presenter, Professor Dr. Saima Jilani, ma'am. Madam has a 7+ years of professional experience and is an assistant professor at Government Medical College, Anantnag, Jammu and Kashmir. And Madam is our NSS number Chapter 7 President of J&K State, is inducted in NSS Head of the Family. Madam has published 20+ articles in national and international referred journals, and she has authored one book titled Health Nursing Informatics and Technology. Madam has participated and organized many workshops and conferences at national and international levels. Madam has received first prize in paper presentation on the theme Save the Girl's Child. And Madam is a lifetime member of TNI, SOMI, NSS, and many more. Now, I would like to invite Professor Dr. Jilani ma'am to present their presentation. Saima ma'am?
Yes, sir. Thank you very much. Am I audible?
Yes, ma'am.
Thank you very much, sir. Thank you for a lovely introduction. Good morning, all the dignitaries, and good evening to Shiv Khanna ma'am. I'm very thankful to Shiv Khanna ma'am that she gave me this opportunity. So coming to the title of the study, my study was a quasi-experimental study to assess the effectiveness of non-traditional birthing positions on labor outcome during the second stage of labor among second gravida mothers in Government Maternity Hospital, Kashmir. As all of we know that developing countries that are like India, maternal and child health is a major public health concern. So maternal and child health services are very important in determining a country's maternal and neonatal morbidity and mortality. So during various phases of the labor, maternal care should attempt to improve the health of the mother as well as the fetus and the newborn. The most stressful portion of delivery is the second stage of labor, and the right position for the mother at this time is very critical for a woman's safe vaginal birth. During the second stage of labor, midwives play a very critical role in ensuring that the mother's position is optimal. Nevertheless, the impact of a mother's position during childbirth remains a subject of debate. So for this purpose, the investigator investigated the effect of non-traditional birthing positions on maternal and fetal outcomes. The main goal should be to provide safe and acceptable alternative positions to women. In present study, I used 5 positions, main 5 positions, non-traditional birthing positions that were hands and knee position, sitting position, squatting position, sideline position, upright positions. Some mothers may choose the hands and knee position, which is also known as all-fours position. It can help the baby turn around in the case of a malpresentation of the head. Since this position uses gravity, it decreases back pain as the mother is able to tilt her hips. Although the sitting and semi-sitting birth positions may seem similar, they are very different. Sitting positions combine the helpful force of gravity with relaxation. A birth ball, rocking, or toilet sitting can be utilized to rest while gravity helps labor progress. Squatting positions are helpful in opening the pelvis to allow a baby to find the optimal position for birth. The squatting position is often regarded as the most natural position, which is very similar to the habitual resting position of the chimpanzees and perhaps many of us. Lateral or sideline positions are beneficial for resting during a long labor, promoting body-wide relaxation and minimizing extramuscular effort. Sideline may help slow the baby's descent down the birth canal, thereby giving the perineum more time to naturally stress. Upright positions or standing positions for childbirth uses gravity to the mother's advantage. They help the baby drop into the pelvis and prevent pressure from being concentrated in a particular spot. They represent the most underused birth positions. The need of the study was, as there is a growing demand for more natural, normal childbirth and non-pharmacological methods for managing childbirth. Among all the non-pharmacological techniques, positions are the only one which does not require the presence of a nurse, as it can be performed by the mother herself. During my clinical experience in the labor rooms, I noticed, sir, that the women in the labor are very anxious and fearful. Due to apprehension, they are not able to cope with the stress during labor. So positioning of the woman at the time of birth is potentially an important clinical factor. Being upright, mobile, or semi-sitting during labor, it provides a right angle for the fetus with the aid of gravity to propel rotation and descent of the fetal head into the pelvis. It was recommended by the World Health Organization in the year 2018 that upright positions and stated women that they should choose the maternal position according to their preference. Although many researchers have shed light on the use of different non-traditional birthing positions during the second stage of labor, but the pros and cons of each position might not be apparent. Researchers believe that giving birth in non-traditional birthing positions can benefit the mother and baby for several physiological reasons. Non-traditional birthing positions have several physiological advantages over the supine position. Non-traditional birthing positions shorten the duration of second stage of labor and reduces the labor pain and decreases the incidence of operative vaginal births. With the effectiveness of various non-traditional birthing positions proved by different studies, the need to stress on the importance of applying different non-traditional birthing positions and provide relevant knowledge of non-traditional birthing positions to women and caregivers. The objectives of the study were, first one, to determine the effectiveness of non-traditional birthing positions on labor outcome during the second stage of labor among second gravida mothers in experimental group. To determine the effect of conventional positions on labor outcome during the second stage of labor among second gravida mothers in control group, and to compare the effect of non-traditional birthing positions and conventional position on labor outcome during the second stage of labor among second gravida mothers in experimental and control group. Many studies were reviewed before carrying out this study, and the literature was divided into literature that is related to the effectiveness of upright birthing positions or labor outcome, which was seen to be very effective, and it has significantly reduced the pain both in the intervention group as compared to the control group. So the study, it was a recent study which was done in the year 2020. Next one, please.
Yes, ma'am.
Yes. Same, these were the studies. This was in the year 2019, where it has been seen that squatting, sitting, kneeling, and upright positions, they were very effective to reduce the labor pain. Next one. This is the schematic representation of conceptual framework that was based on Weidenbach's helping art of clinical nursing theory. So the agent here was nurse, and their context was labor room, that was the government maternity hospital in Anantnag, and central purpose was effectiveness of the non-traditional birthing positions during the second stage of labor on labor outcome, and the recipient was the second gravida mothers. So it was divided into the three, that was administering the needed help, ministering the needed help, and validating the needed help. In administering the needed help, so I took the demographic variables of second gravida mothers, which was divided into the age, educational status, type of family, type of work, area of residence, previous information received regarding non-traditional birthing positions, source of information, food pattern, habit of doing regular exercise, and type of exercise. In experimental group, I developed the interventional strategies or non-traditional birthing positions, which was lateral, sitting, standing, squatting, and kneeling position. I encouraged the mothers to be in selected position for about 15 minutes with a period of 5-minute rest in the left lateral position and continue till the delivery of baby. Whereas in the control group, mothers will follow the routine position during the second stage of labor. And in the post-test, labor outcome was assessed, which includes maternal outcome and neonatal outcome by using the observational checklist, pain intensity scale, UPCAR score, and neonatal course. And the post-test was it was seen whether it will come in the positive outcome or it may be the negative outcome, which was used using the same assessment tools. So the methodology of the study was, the research approach was quantitative, and the research design was quasi-experimental, non-traditional, non-randomized control group design. The setting was maternal hospital, government maternity hospital, Anantnag, and the target population was all the second gravida mothers which were admitted in government maternity hospital. The sample and the sample size was 240 second gravida mothers who were admitted in the labor ward of government maternity hospital. And the sampling technique was purposive sampling. Data collection technique, first, it was the pre-test, which was in terms of the structured interview schedule and the observational checklist. And intervention was done in terms of the non-traditional birthing positions and implemented. Then post-assessment was done using the same tool. And the variables of the study were independent variable, that was the non-traditional birthing positions, 5 positions, sitting, standing, squatting, side lying, and kneeling. Dependent variables were in terms of the labor outcome, which was both a maternal outcome and neonatal outcome. Maternal outcome was in terms of duration of second stage of labor pain, cervical dilatation, rupture of membranes, mode of delivery, and neonatal outcome. That is in terms of by using the UPCAR score, status of baby, birth of any birth trauma, and admission in NICU. The demographic variables were age, educational status, work pattern, residential area, type of family, food pattern, habit of doing regular exercise, type, and duration of exercise. The research design was quasi-experimental. So experimental group was experimental group where we done the pre-test, then treatment, then post-test. NSA was implemented for the control group. So in the pre-test, we done the assessment of the demographic, clinical, and maternal parameters before the intervention. And during the intervention, non-traditional birthing positions were implemented. And in the post-test, assessment of maternal and neonatal outcome was done using after the intervention. The criteria for sample selection was inclusion and exclusion criteria. So inclusion criteria were delivering for mothers, second gravida mothers who were delivering for second time, who were in the second stage of labor with cervical dilatation 8 centimeter per vaginal findings, where with no associated medical or obstetrical complications, were willing to participate in the study, who understand is Kashmiri or Urdu. So in the exclusion criteria, we excluded the second gravida mothers who were categorized under high risk pregnancy, which includes obstetrical complications, pregnancy-induced hypertension, gestational diabetes mellitus, antepartum hemorrhage, multiple pregnancy, cephalopelvic disproportion, malposition, malpresentation, cord prolapse, cord presentation, anemia, complicating pregnancy. Also, mothers who were having the were excluded from the study who were having the medical disorders like cardiovascular disease, hypertension, diabetes mellitus, epilepsy, or gynecological disorders having fibroid uterus, bicoordinate or septate uterus, with complicated pregnancy like obstetric labor, multiple pregnancies, and preterm labor, planned for elective cesarean section, who underwent treatment for infertility, not available during the period of data collection. Sample and sampling technique. The present study was conducted among 240 second gravida mothers admitted in government maternity hospital. In this, 120 mothers were assigned to a control group and 120 mothers were assumed to be in experimental group. So the sampling technique was non-probability purposive sampling technique was used to select 240 second gravida mothers admitted in government maternity hospital as a sample for the present study. The researchers selected antenatal clinic, labor rooms, stage 1st and stage 2nd, postnatal ward for the feasibility of conducting this study. The tool constructed for this study was divided into two sections. Section A, that was structured interview schedule, which consists of two parts. This part of the tool comprises of questions related to demographic variables, and it consists of 10 items. That was age, education, working status, type of family, area of residence, previous information received regarding upright birthing positions, source of information, habit of doing regular exercise, type of exercise, and duration of exercise. And in the part second, clinical variable pro forma consists of 5 items related to clinical variables of mother, which includes gestational age in weeks, height in centimeters, weight gain during pregnancy, number of antenatal visits till date, complications during antenatal period. Next, please. Observational checklist, previous one.
Yes, ma'am.
Observation part second was the observational checklist. This tool was used by the researchers to measure the progress of labor, mode of delivery, and duration of labor. And part third, that was the visual analog pain severity scale. The researchers accepted and uses the standardized linear scale created by the Caffrey and De Pastro to measure the pain severity before and after the intervention. It is a 10 centimeter long horizontal line which that represents the subjective pain intensity rating. It has 0 to 10 point number scale, which where 0 indicates no pain, 1 to 2 indicates mild pain, 4 to 6 indicates moderate pain, and 7 to 10 indicating severe pain. Data analysis plan. The data was collected and analyzed by using descriptive and inferential statistical package for SPSS was utilized for the statistical analysis. Frequency and percentage distribution was used to describe the demographic variables. Mean and standard deviation was used to assess the effectiveness of non-traditional birthing positions on labor outcome during second stage of labor. Both chi-square and t-tests were used for comparing data quantitatively as well as qualitatively. Statistical significance was considered at p-value less than 0.05 and highly significant difference obtained at p less than 0.01. This is the frequency and percentage distribution of clinical variables of alternate methods with respect to gestational age, height, weight gain during pregnancy, number of antenatal visits, and complications during antenatal period. So, among the gestational age in weeks, the majority of the mothers were in the gestational age of 38 to 39 weeks of gestation, and majority of the mothers were having more than 145 centimeter of height, and majority of the mothers have gained more than 12 kgs of the weight, and majority of the mothers have done more than 3 visits, or more than 3 times of antenatal visits, and majority of the mothers were not having any complications during the antenatal period. The table is showing the assessment of labor outcome among parturient mothers in experimental and control group, which is showing that duration, majority of the mothers were having 1 hour of, in the experimental group, it was majority of the mothers were having 1 hour of labor duration, whereas in the control group, majority of the mothers showing the majority of the mothers were having 1 hour of labor duration, whereas in terms of the rate of cervical dilatation, majority of the mothers were having more than 1 centimeter per hour cervical dilatation, whereas in the control group, the majority of the mothers were having 1 centimeter per hour rate of cervical dilatation. So in terms of pain during the labor, in the experimental group, the majority of the mothers shows the moderate pain, whereas in the control group, the majority of the mothers showing the severe pain during the labor. In terms of rupture of membranes, the majority of the mothers in the experimental group as well as in the control group were having the spontaneous rupture of membranes. And mode of delivery, in terms of mode of delivery, the majority of the mothers in the experimental group were having the normal vaginal difference as well as in the experimental group. So there was not much difference in terms of the mode of delivery. So the table is showing the frequency and percentage distribution of fetal outcome among parturient mothers with respect to number of fetuses, birth status of baby, birth weight, APGAR score, evidence of birth trauma, and admission in NICU. So the first was there as a in terms of fetal outcome, the majority of the mothers were having in a single baby, both in the experimental group and the control group. And birth status of the baby, majority of the babies were born without having any complications in both the experimental group and in the control group. In terms of the birth weight, the majority of the babies were having 2.5 to 3 kgs of birth weight, both in the experimental and in the control group. And in terms of the APGAR score, the majority of the babies were having having the 7 to 10 score in both the experimental group and control group. And evidence of the birth trauma, majority of the babies were not having any evidence of the birth trauma, but there were the difference in the some were having the birth trauma in the control group as compared to the experimental group. So admission in the NICU, very less number of the babies required the NICU admission, both in experimental as well as in the control group. Section 3rd, it will give the effectiveness of the it is actually non-traditional birthing positions on labor outcome among the parturient mothers. This table is showing the comparison of mean and standard deviation of maternal outcome, duration of labor, rate of cervical dilatation, intensity of uterine contractions between the experimental group and control group. The mean and the standard deviation first is the duration of the labor. So P was significant. So duration of the labor, there was a difference between the experimental and the control group. In terms of the rate of cervical dilatation, it has been shown this was also significant. And pain during the labor, it was also shown that there was a much difference between the experimental and control group. So it was also significant. Next one is the rupture of the membranes. It was a non-significant because both the groups were having the spontaneous rupture of the membranes. Mode of delivery, it has also seen that there was a much difference, so this was significant. So this is the graphic representation of the comparison of mean and standard deviation in experimental and control group in terms of duration of labor, pain during labor, and comparing the duration of labor in both groups. The mean score was 1.49 to 1.88, and the calculated t-value was -0.39, which was greater than the tabulated value, and indicating that there was a high statistical significant difference in duration of labor as 0.05 level of significance. With regard to rate of cervical dilatation in experimental group, the mean score was 2.47, whereas in the control group it was 2.04. With regard to pain during labor, mean score was 1 in experimental group and 2.09 in control group, that indicating that there was statistical significant difference between the experimental group and control group. The study reveals that there was a highly statistical significant difference, p less than 0.001, among the experimental group and control groups in the mean duration, labor duration, rate of cervical dilatation, and pain during the labor. The obtained p-value was found to be significant as 0.05 level of significance, which indicates that non-traditional birthing positions were effective in improving maternal outcome. Coming to the discussion of this study, the present study intends to evaluate the effect of non-traditional birthing positions on maternal outcome during second stage of labor among second gravida mothers. The present study depicts that non-traditional birthing positions, when compared with conventional position, had significant effect on maternal outcome. Calculated t-value of all parameters was greater than tabulated value, so non-traditional birthing positions had significant effect on maternal outcome at p-values less than 0.05 level of significance. Non-traditional birthing positions has a good impact in terms of APGAR score and NICU admissions. There may be less need for admissions in NICU who give birth in non-traditional birthing positions. According to a systematic study by Walker et al., the present study showed a significant difference in APGAR score and NICU admission of babies delivered in two groups, which is consistent with Cochrane Review 2017, studies conducted by Dijon 2014 and Morgullo et al., which were conducted in the year 16, 17, and 19. A pregnant woman should be encouraged to walk about and give birth in a position that is most convenient for her. So the recommendations of the study were: encourage partner mothers to assume non-traditional birthing positions during second stage of labor. Partner mothers should be encouraged to choose a comfortable position. Researchers who want to compare various delivery positions should use research designs that allow women to choose their preferred birthing positions. Develop an education program for pregnant women regarding the benefits of non-traditional birthing positions for both mothers and newborns through posters, videos, brochures, or pamphlets at antenatal clinics to improve the partner mothers' awareness. Apply the findings of the study to develop health education programs in hospitals, community health centers, and community areas. A comparative research can be conducted to assess the effectiveness of other non-traditional birthing positions on labor outcome, that is kneeling, squatting, standing, and handstand position. So these were the references of my study that I used. Same. Thank you very much for your patience. Thank you very much.
Thank you, ma'am. Thank you for your wonderful session. Ma'am, Dr. Geeta, ma'am, any feedback?
Yes, thank you so much for good presentation, and your result findings are also very clear. I just have 1 or 2 points to ask. First of all, regarding the ethical permission for non-traditional that you were able to manage?
No, ma'am, I faced many difficulties for the ethical permission, but at the end, there was many difficulties that faced for this study. But after, I think it took me almost for the ethical permission almost 2 years.
Okay. And any structured training you have taken, like all these deliveries were conducted by you, or you had taken some assistant with some formal training?
Yes, ma'am. I took a training online. That was the from birth centers who were conducting the normal normal deliveries. So I took that. That was the COVID period, and I took that training online only.
Okay. And is
Yes,
this
ma'am.
MLCU concept, that midwifery-led care unit concept, is started in your state?
No, ma'am. It has not been started yet here. We are
Okay,
waiting
and
for that.
midwifery guidelines to 2018 now, as you know, released by Ministry
Yes,
of
ma'am.
Family Welfare. They have also mentioned about upright position
Yes, ma'am.
by
Yes, ma'am.
midwife.
Yes,
So
ma'am.
yeah. So you have done a good job in contributing. Like already you have taken initiative. And one
Thank
more
you very much.
small queries, I think I may missed in one of the slide regarding the age of mother in your participant. They were ranging between which age?
It was actually age was beyond the 30 years, because second gravida there are actually in Kashmir every mother would be beyond the, because late marriages are going here, so beyond 30 ही मिल जाएंगे आपको, तो I took that beyond the 30.
Or beyond 30,
Mm.
and they were second gravida, plus
Mothers,
they
yes,
gave
ma'am.
consent for the upright position. Yeah.
Yes, ma'am. Yes,
Thank
ma'am.
you. Thank you for clearing all my
Thank you.
queries.
Thank you,
Okay.
ma'am.
Ma'am, Khanna
Yeah,
ma'am,
thank-
anything feedback, ma'am? Khanna ma'am? Khanna ma'am? Okay.
It's not audible.
Now it's audible, ma'am?
No, no.
I'm not audible, ma'am.
You are
Yes,
audible.
you are
Khanna ma'am.
audible.
Khanna ma'am? Okay, now I would like to introduce Professor Dr. Alka Tajani ma'am, our NSS General Secretary.
I would like to ask one question.
Yes, ma'am,
Yeah.
please, ma'am.
So thank you very much and congratulations for a wonderful presentation. It is really, eye-opening, for the birthing the baby. Underwater birthing is also is one of the very, very good, non-traditional positioning method, which has been established and evidence-based. And one thing I would like to ask the presenter, that when you said, in relation to age, in relation to birth weight of the child, in traditional and in non-traditional positioning, how the weight of the child will differ. Weight of the child will remain the same, no? You said there was variation in the weight also of the child. So can you throw this highlight on this?
Yes, ma'am. There was, because it has been seen in both the experimental group and the control group. There was
Yeah.
not a difference in the birth weight of the child. Both the groups, the weight was same. It was actually the what I have seen in many of the studies based on the evidences that I took these parameters.
Okay. And one thing more, the postpartum. Did you study the postpartum period also in both the groups? Whether there is any infection postpartum or any.
No, ma'am. No, ma'am. That was not
You did not
the
study.
part of it. No, ma'am.
You did not study that.
No.
Okay. Thank you.
Okay, ma'am. Thank you, ma'am. Now I would like to introduce Professor Dr. Alka Tajani madam, our NSS Secretary General, for brief report on international conference held on Surat on January 8th and 9th, 2024. Madam is currently working as a principal of Vibrant Nursing College in Surat, and Madam has extensive clinical as well as teaching experience and is very actively involved in her students all around growth during their training period. Madam has recently had a very successful international conference in collaboration with NSS headquarters. We invite her to present a brief report on 2 days proceeding of the first international nursing conference with a great. Over to you, ma'am.
Kudos to Dr.
Thank you,
Alka.
sir. Yes, ma'am. Yes, ma'am. Good morning, ma'am. Good morning.
Good.
I'm very happy to present this report. Sir, please share the slide.
Yes, ma'am. You can share, ma'am.
No. You can share. I have sent it already, sir.
You shared with me, ma'am.
Binu, sir, I have sent.
No, I don't have that data, ma'am. If you have, you just share with me, ma'am, so that is
Actually, I'm presenting on a mobile, so please.
No, you have in the WhatsApp, ma'am.
Yeah, yes.
Yeah, please. You please share it.
Binu, sir, is there?
No.
I think he's busy, ma'am. Ma'am,
I
you just
think
share
Binu-
to
Madam
my
also
number.
have it. I
Madam
didn't have
has
your number, sir.
Do you have in your hand? Just read.
I think
No,
Binu is not there. You can share it to.
Hello,
Ma'am, you
ma'am.
can
Khanna,
share
ma'am,
with
you
me,
have.
ma'am. I can share.
No, it is with. Hello, ma'am. Sorry, Khanna, ma'am, you have that. I have sent it. Sir, to sir because I didn't have a number of sir. And then I think.
My WhatsApp is not working.
Okay. So can I read from WhatsApp only because I'll then I'll stop this.
Yes, please.
Yes, ma'am.
Alka, you can share it to me. I'll share your screen.
Yes.
Otherwise, you can just read from your WhatsApp PPT. No problem.
I'm sending, ma'am. I have saved you, ma'am.
Sure.
Hello, sir. You can make co-host to Dr. Asha Kuresh, ma'am. Then only she will share.
Yes, ma'am. Madam, she can.
Yeah.
Madam
How
can
to
share.
share, how to share from the WhatsApp. I have to save this to the, I think, photos.
No, ma'am, you should share the screen, ma'am.
Yeah, I can share, but from the WhatsApp it's not been shared. So I will just, save to the file, Acrobat.
Sema, good to see you, Sema.
Ma'am, my video was off. I don't
Yeah,
know.
ma'am. That is the reason I put you, ma'am. Madam was asking repeatedly, Khanna ma'am.
I was not aware, sorry.
It's all right. As far as we could see you at the end.
Thank you very much, ma'am.
But very clear audio.
Yes, ma'am.
Alkaji from WhatsApp, it's not been shared.
Okay.
Just read.
Yeah.
Just read
Okay, I'll
first.
read, ma'am. I'll read. But
Please.
I want to share two photos. That's why the slide I have prepared, ma'am.
Yeah, everybody can
Okay,
see.
I'll
I will share to everyone so that everyone can see in the WhatsApp.
Okay,
Have you
ma'am.
In the
shared, ma'am?
group. Yeah, I will send it in the group of NSS.
Yeah, you please share, ma'am. That would.
Yeah. Yeah,
Okay, so
I've already sent to everyone.
Yes.
So
Yes,
now
ma'am.
you
Yes,
can
ma'am.
open your phone and you can see her presentation.
Yeah.
It's
So
beautifully
good
prepared.
morning, yes, madam. Good morning to everyone, distinguished dignitaries. And it's my immense pleasure that I'm presenting the international conference report. The first international conference was organized in Vibrant Nursing College with the collaboration with the Nursing Scholars Society on 8th and 9th January 2024 in the presence of our patron Dr. Swaresh Narula Khanna ma'am, our national advisor Dr. Bimla Kapoor ma'am, and our SNT president Dr. Asha Kurish ma'am, national president Binu Josh sir, Anu Joy Kute madam, Dr. Sudha, Dr. Mr. Professor Himanshu Trivedi sir, and the chairperson from Vibrant Nursing College, Mr. Dinesh Bhai Gondelia, and the director Kamlesh Bhai Jagani. So the planning of international conference was started first year before in a national conference organized by Subharati Nursing College in a Meerut. Since 6 months, we are having many online meetings with Dr. Vimla Kapoor ma'am and Dr. Asha Kurishi madam, and there were many speakers have changed. But myself, I think all the NSS executive we say, yes, it is a proud moment for everyone that what we decided beyond that, our first international conference was a grand success. And I'm very happy. Whenever, if I'll share this, anywhere, if I'll go, and the fever of conference is still going on. Everyone is asking, I'm going for examination or I'm visiting any university. They're asking that the conference was fabulous. This conference was online and offline mode also. Everyone is satisfied with the accommodation, the food, and the facilities like a transportation and all. The conference was inaugurated with the lamp lighting.
I think all of you can see the screen now.
The
Screen
welcome
share
dance
has
was
been
performed
done.
by.
Yes, ma'am. Yeah, I
Yes,
have
ma'am.
shared.
Yes.
I already have shared.
Yeah, screen
Thank you
share
so
has
much.
been done. Please see now.
Yes, thank you so much.
Please unmute.
I don't know
Lot of
who's.
noise is coming.
What can do it?
Just a minute.
Lot of noise. Please mute yourself.
Okay.
Who is Rano Bag? Please. Okay, ma'am.
Okay, sir. So there was a batch set. Sir, please share the slide. Put an executive member, and then we all have put a batch to madam. On the first evening, there was a cultural program performed by various colleges in South Gujarat and from Surat and the Navsari College. And after that, the speakers have given their opinion as per the brochure we have prepared. So please, sir.
Yes, ma'am.
So these are some of the glimpses I'm sharing with you all. The master of ceremony, where our treasurer, Dr. Anu Joy Kute madam, with our associate professor from Vibrant Nursing College. And there was a felicitation done by our trustee Mr. Gondalia, to Bimla Kapoor ma'am also, and our Swaresh Khanna ma'am also. And after that, all the speakers have shared their views regarding this, according to what are the topic we have selected and we have given to them. And the conference was a grand success. Now there were, sir, last you can show me.
This is the last
There
slide,
were
ma'am.
total, yeah, no, it's a written over there. The report is there. These are the photos, sir.
No, ma'am. No
Before
report, ma'am.
that.
Before
No,
that,
it is
okay.
there. It is there.
This is the report, ma'am.
No, these are the photos before this. Okay. Just before this. Okay, anyway, the conference was Tuesday, 8th and 9th, and total 1,200 and above the participant was participated, and among that 115, I think, there was online, and others are offline only. And the feedback we have sent it to our Gujarat Nursing Council, that it is successfully conducted, and the Gujarat Nursing Council, who is given 10 credit hours for this conference. Sorry. So I'm so happy that we have organized and we have a grand success in Veer Narmad Gujarat University in Surat. We have done this conference. So thank you so much, everyone, those who have participated, those who have.
Thank you,
ma'am.
Dr. Alka. Thank you. It was nice, conference organized
We
by
have
you
a lot,
under
and
your
I'm
leadership.
so much happy, and thank you to Dr. Khanna madam that when she came and she landed over here, the burden is gone, all the burden, along with the Binu sir and Anu ma'am also. So by seeing these people, I was feeling like my half of the tension have gone, and then the conference was a grand success.
I enjoyed
Thank
it.
you, everyone.
Okay.
Thank
Coming
Thank you,
to,
ma'am.
are you invited?
Next, I would like to, yes, ma'am. Now I would like to call our patron, ma'am, for vote of thanks. Ma'am, over to you, ma'am.
Thank you, Muthu, sir. I would like to thank our NSS President, Professor Dr. Binu Jo, sir, for providing Zoom facility and being here. Our Vice President and Chief Guest, Principal Professor Dr. Priyesh Janji, for honoring us with his presence in court, like he has said he wanted to. Our sincere thanks to both our respected special guests, though she couldn't be here, Professor Bimla Kapoorji, and SNT President Professor Dr. Ashia ji is here, and I am eternally thankful to her for her input, for feedback, and for giving moral support, you name it. Her unconditional support is by far so much that I cannot explain in words. Thanks are due to our guest of honor, Professor Geeta Parwandaji, for graciously accepting dual role of guest of honor as well as of a resource person and providing important response to our presenters' study presentations. Thanks with utmost gratitude is due to our talented presenters who presented their studies while focusing on findings and implications in enhancing quality of nursing care of our patients. Thanks are due to Dr. Nirja ji, Dr. Rita Lakhani ji, and Dr. Sama Jilani Habib ji. Last but not least, to our MC of second portion, Professor Dr. Muthu Chavdanawar Ji, who was our respected guest of honor as well as MC today. Also developing the PPT for this webinar session internally with gratitude to you, sir. Really, it was such a successful PPT, very clear and on time. Thank you very much. I think
Thank you,
we are
ma'am.
ready to adjourn.
Yes, ma'am. Thank you so much, ma'am.
Thanks to all of
Thank you.
you for being here. Good night from my side.
Thank you, ma'am.
Good
Thank
night,
you all.
Thank you,
ma'am. Good
ma'am.
night.
Jai
Thank
Hind,
you.
ma'am.
Good night, ma'am.
Congratulations to everyone.
Thank you.
And Alka ji, really,
Thank you so much.
it was such a pleasure. I'm still dreaming about that India trip and being there with you all. Thank you. And Asha ji, thank you for your gift and also inviting us in
Yes, yes, we also, ma'am. Thank you so much, ma'am.
Yeah.
Thank you so
Thank
much, ma'am. It is our privilege.
It
We
was-
are proud that,
it was
to
beautiful.
have you.
Yeah. Thank you to all.
Thank you, ma'am. Thank you.
Thank you, ma'am.
Thank you, Muttu sir. Perfect.
Yes. Thank you, ma'am. Thank you so much. Shall I end, ma'am?
Yeah.
Yes, we can.
Thank you, ma'am. Thank you for the wonderful day today.
Thank you, Gita ji.
Thank you, Dr. Geeta.
Thank
Seeing
you,
you after
ma'am.
a long time, after the conference, I am seeing you for the first time. Thank you so
Ah,
much.
yeah.
Nice to
Yeah,
have
ma'am,
you on the
hoping to
forum.
see you soon. Yes, ma'am. Jai
Yeah.
Hind, ma'am. Jai Hind. Hi.
Yeah.
Thank you,
Thank
Geeta
you so
ma'am.
much.
Jai Hind.
Thank you. Jai Hind, ma'am.
Thank you,
I'm
Geeta.
also
ma'am.
seeing after a long
Thank
time,
you.
after 1 year.
Thank you,
But
Alka
ma'am,
ji.
ऐसे
Thank you,
मिलते
Alka
रहे
ji.
जी.
We are still,
Thank you, Asya Kureshi ma'am.
that Gujarat conference is still, we can't forget,
Yes,
the
yes.
way
Thank you so much,
your
ma'am.
hospitality and the organization and everything, It was
Thank you.
beautifully
Thank
and
you.
wonderfully done.
Thank you so much, ma'am.
Yeah.
I see Parvinder also. Parvinder Kaur, thank you, Ji, for your comments and positive. Thank you, Parvinder. You're muted.
Shall I end it, ma'am?
Yes, I think you can end it now.
Yes, 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 ma'am.
Yeah.
Thank you. Thank you so much, ma'am. Thanks for joining.
Okay. Thank you. Thank you, everyone.
Have a good day, ma'am.
Have a good day. Have a good day.